Hello, everybody. My name is Sebastian Champagne. Today, we will be talking about smart technology in regional anesthesia. We'll be enhancing safety to injection pressure monitoring in AI-enabled ultrasound. Our objective will be looking at the nerve injury in regional anesthesia, purpose of it, the standard and regulation, legal and ethical issues. We also look at the overview of the devices for pressure monitoring, ultrasound with AI and regional anesthesia, and also the synergistic use of using both devices together in a dual modality safety. We're also going to look at the anesthesia workflow processes, and we're also going to look at the security, privacy, and ethics. And lastly, we're going to look at the implication for nurse anesthesia practices. So, the field of anesthesia is currently being profoundly reshaped by health informatics, offering innovative tools and strategy that move beyond traditional practices. Anesthesia is one of the specialty, if not the most rich, data-rich specialty, and is uniquely positioned at the crossroad between technology and biology. So, and every anesthesia case will generate a stream of physiologic waveform, medication log, imaging studies, plus we use multiple monitors at the same time that generates data as well. And it makes it a prime area for the application of advanced computational ability. So artificial intelligence is progressing rapidly. Now it's capable of autonomous self-learning and adaptive behavior. It has evolved far beyond its earlier limitation that mimics human actions. It's opening the door to knowledgeable and independent system. So this evolution is driving a technology shift, and AI is being integrated into various healthcare domains. This is producing significant benefit for the overall healthcare system. And one particular subfield in anesthesia that can benefit significantly from this technology shift with AI is regional anesthesia and the prevention of nerve damage. So let's start with the problem we battle every day in the blood world. So nerve injury, even in 2025, when virtually every block is ultrasound guided, so permanent injury still occurs in roughly 1% of patients and transient deficit and up to 8%. So study using cadavers and live imagings show that we inadvertently enter the nerves itself about 15 to 17% of the time in common blocks like the interscaling and the sciatic. So why does that happen? First, ultrasound is only as good as our interpretation. So a faint echo or momentarily loss of the needle view can fool even the experienced hand. So if we inject under high pressure inside the nerve, we add mechanical trauma, ischemia, and local anesthetic neurotoxicity to the mix. So second, regional anesthesia is a true two-handed skill. So one hand steers the probe and the other advances the needle, while our eyes dart between the screen and the patient. So Pocora and colleagues show that this constant hand-in-hand choreography lengthens procedure time and can displace the needle when we're not looking. So novice struggles even more. So common errors are advancing without a visual needle tips or sliding the probe off the targets. So all of this tells us that traditional ultrasound alone isn't enough. We need smarter informatics, driven safety layers, AI image overlays, and real-time pressure alarms that warns us that instant position and injection pressures turns dangerous. So first, let's first look at why we still need better safeguards. So on the left of the graph, you see a transient neuropathy rate, about 3% overall, slightly less for the brachial plexus block, and only a third of the percent of femoral block. So it looks like femoral block maybe might be a bigger area for you to develop. So the percentage is really low in that block, but in the middle bar set, the real eye opener is intentionally internal injection. It climbs to nearly 17% for brachial plexus procedure and hover around 16% overall, even with ultrasound guidance. So persistent or permanent neuropathy show on the right is thankfully rare, roughly 3 in a 10,000 blocks, but the stakes are obviously high when it occurs. Those numbers highlight our exposure. Most injury are preventable if we can see the needle tip. So measure injection pressure and patch warning sign in real time. So the purpose is real-time needle tip identification, trajectory tracking. So we can get a raw ultrasound is noisy and two-dimensional. So AI overlay and pressure sensor can tell us exactly where the tip is and whether it's drifting into danger. So you're gonna master ultrasound image interpretation. So by letting an algorithm pre-label nerves, a vessel, and facial planes, we shorten the learning curve and cut the cognitive load during every block. So integration with decision support. So when depth, angle, and pressure data stream directly into the EMR via the HLS, HL7, and FHIR, the system can auto alert if injection pressure spike or the needle veers off course. So we can prevent fragmented documentation. So automated capture replaces manual note taking, giving us a complete timestamp record for quality review and malpractice defenses. So automated and enhanced image analysis and guidance. Together, AI-enabled ultrasound and smart pressure monitoring serve as a dual safeguard, bringing objective metric to skill set that has traditionally relied on experience and haptic feel alone. So standard and regulation. So we're gonna look at the existing and evolving standard for the block procedures. Ultrasound guidance is continuing to be the gold standard. So real-time visualization improve accuracy and safety. So ultrasound guidelines, the American Society of Regional Anesthesia and Pain Medicine, they advise avoiding deliberate intraneural contact and encourage multimodal monitoring when evidence support added safety. So the combined modalities, so evidence is mixed. So dual or triple monitoring can help detect intraneural needle placement, but well-designed studies are still limited. So injection pressure monitoring, so device that block or warns above approximately 15 psi show promise in reducing nerve injury risk. So no nerve injury has been reported when injection pressure monitoring is used correctly. So patient state. So keeping patient awake to detect paresthesia is no longer absolute. So blood under general anesthesia are common in pediatric, and nerve damage can occur painlessly. Regulatory approval for new technology. So the FDA clear AI devices, so platform like ScanNav in 2022, and either AI guided system. We have also nerve blocks and nerve strikes are now recognized. They creating a new AI supported regional anesthesia device class. So the ethic oversight of this, we have a human and animal research must first pass review, ensuring safety, transparency, and compliance before any clinical deployment. So some challenges in standardization and regulation. So evidence gap, current guideline rely on low to moderate quality data. So we need robust RCTs comparing AI and monitoring combination are scarce. So research heterogeneity. So study varied widely in design and reporting. So only a few follow consort AI decide AI standard complicating meta-analysis. So data quality and transparency. So AI performance depend on high quality data sets, yet industry data sharing is inconsistent. This leads to a variable regulatory scrutiny. So medical, legal, and ethical issues. So AI does not replace clinical responsibility. Provider remain accountable for patient safety, data, privacy, and ethical use of emerging technology. So legal and ethical issues, accountability and responsibility. First, let's clarify who owns the outcome. So when AI overlay is on the screen, the software can suggest, but it can decide. If the block goes wrong, liability still rests with the anesthetic. Think of AI as an image augmentation, not an autopilot. So that distinction is critical in court, especially for patients who already have neuropathy, where any post-op is quickly blamed on the block. So data security and patient privacy. So AI systems thrive on big data sets. So every pixels of an ultrasound clip is PHI. So once it's linked to the chart, we need HIPAA level encryption. Audit logs and clear rules on secondary use, even if the image appear anonymous. For ethical principle in AI design, institutes like the Alan Turing Press four pillars, which is fairness, accountability, sustainability, transparency. In practice, that means bias monitoring, unexplained algorithm, and human override at every step. Today, we still lack a unified clinical standard for safe by design. So AI in regional anesthesia. So professional bodies and regulators needs to fill that gap. So for informed consent and risk disclosure, so patients, especially those with pre-existing nerve disease, they deserve an honest discussion of block risk. So AI benefits and alternatives. You have to document that conversation just as thoroughly as the block itself. So for training and practitioner confidence, finally AI can boost novice confidence, but over reliance is dangerous. So if the overlay highlight the wrong structure, and an uncritical user may follow it. So we still need a solid sonal anatomy skills and seasoned mentors. AI assists if AI assists, it never substitutes expert judgment. So bottom line, you're gonna adopt AI for its safety upside, but you have to anchor its use in robust privacy safeguard, transparent algorithm, rigorous training, and unwavering human accountability. So now we're gonna talk about the monitor device that's on the market. So first we're gonna take why is pressure monitoring matters. So anything greater than 15 psi strongly suggests intraneural and intravascular placement. This is an increased risk for permanent nerve injury. So the informative goal capture pressure values, timestamp them, and then feed data into the EHR and it's good for research as well. So we're gonna compare some of the devices that we have in the market today. So we have the Saphira. The Saphira is the one in the middle right here. NerveGuard is the green one, and also the white one is the Be Smart. So some comparison of the of that we see right now. The Saphira, what can it detect? So it has an electronic sensor flash, so anything that's above 15 psi, it will like automatically stop, but it will still allow you to aspirate, but like it will hurt you, you won't be able to inject. Um, you can override that, and then the one good thing about the Saphira that we can see, I think, is that little device, the white and the green, like it give the user I think it's a foot pedal that you can use to aspirate and then you can inject with that device. So like you only need like you can be by yourself, use the ultrasound and be able to do the whole thing by yourself. Compared to the other one, you will need like a second person to do it. One thing that the Nerve Guard has in common with the Saphira, it's also at anything greater than 15 PSI, it will actually automatically block you from actually injecting if the pressure is really higher than 15. Um, but you again, like I mentioned, you will need two-person, the one with the ultrasound with the needle placement, and somebody to aspirate and inject. The B Smart, on the other hand, this one give you a color-coded warning. So there's like three color. I don't know if you can see in the picture. So the top one is white, the middle one is yellow, and the orange one is 20. So the white one is less than 15 psi. Yellow is between 15 and 20 psi, and then orange is greater than 20 psi. So the one thing about the Be Smart, like it will give you the pressure, it will give you the pressure reading, but it give you autonomy to decide, hey, I can see the needle placement in the ultrasound. I know it's reading high. I think it's safe to inject. I think I'm still gonna do it. Or you can be like, okay, it's reading really high. I'm just gonna move my needle and place it somewhere else. And also you need like two operators for it as well. So the Bismarck give you the autonomy to decide if you want to inject, regardless if the pressure reading higher and everything. So it's up to you as a provider, like with experience or you know what you're gonna do to do that. So the informatic implication of the Sapphira, so the Sapphira and Navga, they are true pressure limiters. They integrated well with automated recorders, ideal for single shot or continuous block. Where the data captures matters. So BeSmart is affordable visual aid, but relies on user vigilance, like I mentioned. So there's no continuous readout. So future stream high frequency ratio data to dashboard. So real time decision support and post case analytics. So again, just to bottom line is the Be Smart, it warns you, but it doesn't stop you. Nerve Guard adds a mechanical safety lock at 15 psi, though it still needs a second pair of hands. And the Safira, it goes further with single operator automation. It gives you electronic feedback, and it's a built-in hard limit for safer, streamlined nerve block delivery. Now we're gonna look at smart ultrasound plus the AI and regional anesthesia. So, artificial intelligence is rapidly moving from its interesting demo to daily tools and regional anesthesia. So, traditional ultrasound depends on our eyes and experience. Subtle structures or off-axis needle tip are easy to miss. So AI split that. It ingests every frame in real time, runs a convolutional neural network, usually a U-net segmentation model, and an intense color overlay of bounding boxes around nerves, vessels, and facial planes. So there's a built-in system. We already shipping on the card. The General Electric Venue Cleaner went to the FDA in June 2022. Mindray Smart Nerve of the brachial plexus that was cleared in late 2021. Samsung Nerve Track added a box style highlighting a few months earlier, and then handheld like Philips, Lumified, and Clarion have followed suit. There's an external overlay that they have as well. I think I mentioned that earlier. It works with any existing scanner, like ScanNav, Peripheral Blog is the first FDA cleared AI assistant for block, plugged in a block via HDMI. It highlights 10 common blocks, anatomies, and even drives a needle trainer simulator. And Nerve Block uses the same unit architecture to color-coded muscle, pleura, vessel, and plexus. So why does this matter? So real-time labeling improves needle tips, visibility, it helps us avoid intraparticular path, and it gives novice objective cues instead of a guess and check when paired with smart question monitoring. So AI ultrasound forms the second half of the dual safety net. This is reducing operator dependence on paving the way for integrated decision support in the block room. So the safest way to deliver a block is to answer two questions in real time. Where exactly is my needle tip and what am I injecting with? So AI enhanced ultrasound tackles the first. The algorithm highlight nerves, vessel, and the optimal fascia plane so we can steer the needle directly into the safe window instead of relying only on mental reconstruction of a grainy image. So question monitoring, be smart. So be smart, nerve guard, and Porphyria. They lock down the second. They read resistance every millisecond and warn us physically stop flow once pressure hits 15 psi. The threshold is strongly associated with intravascular or intravascular placement. It puts together, we get true redundancy. So visualization plus objective metrics. So Kudre and colleagues, they prove one of their research, they proved the concept in a randomized trial. Adding needle tip pressure sensing and minimal nerve stimulation, it cuts unintentional intraneural injection from almost 13% down to under 1%. That's amazing. Some authors worry that multiple gadgets could clutter the field or prompt unnecessary needle movement, but the data trend is clear. Dual or triple monitoring lower injury rates. It boosts the RNA confidence and it gives educators a protocol to teach. Bottom line, all AI tell us where to inject, pressure monitoring tell us how to inject. So safely together, they form a digital seatbelt for every nerve block. Now let's look at the workflow process. So first, let's look at the benefits. So smart technology, such as AI-guided ultrasound and devices like Safira, streamline regional anesthesia procedure, reducing procedure time up to 20%. As noted by Bowness in 2024, This efficiency boosts operating room to throughput and enhance CRNA productivity. This allows more patients to be treated effectively. Additionally, AI-guided ultrasound systems are exceptionally educational tools. According to Mike and colleagues, in 2024, they helped trainees and novice anesthesiologists bridge the gap in anatomical knowledge, accelerating skill acquisition. So clinically, this technology reduces nerve injury rates, it increases CRNA confidence, and it supports standardized protocol as evidenced by Kudre and colleagues in 2021. So standardization ensure consistency across procedure, so which is critical for both patient safety and training. So some challenges that we're gonna see, however, integrating this technology into clinical workflow isn't without any challenge, all right? So we get resistance to change is a significant barrier with some CRNAs and surgeons preferring traditional methods as highlighted by Paniski and his colleagues. The high cost of device such as the Fira or AI-enabled ultrasound system can limit access, particularly in smaller facilities. Additionally, success, successful adoption requires comprehensive training and integration. With existing systems like anesthesia information management system, even with this advanced tool, nerve injury can still occur due to patient-related factors such as pre-existing neuropathy or systemic disease like diabetes, as well as surgical factors like patient positioning or tourniquet use. As noted by Baez and his colleague, the limitation underscore the need for holistic approach to risk management. So smart technology enhanced workflow efficiency, training and patient safety in regional anesthesia, while their adoption required overcoming resistance, addressing costs, and managing patient-specific risks. By investing in training and integration, we can maximize the potential to transform CRNA practice. So now we're going to look at data security and patient privacy. So the adoption of this advanced informatics mechanism necessitates careful consideration of security, privacy, and ethical implication for nurse anesthesia practice. So we have a data hungry algorithm. This required a huge image library and proper handling invites breaches. So even anonymous data need governance, such as HIPAA, GDPR, or local equivalent. Oppressed privacy, which is a hidden erosion of patients' right if institutions are lax. So we have a core ethical principle from Alan Turing Institute framework. So fairness, we mitigate algorithm bias, such as skin tone dependent on ultrasound artifacts, so we have to take accountability. If an AI mislabel an anatomy, the CRNA, not the software vendor, is still responsible. So a major ethical consideration is who bears responsibility if an error occurred. So while using AI-assisted system, it is consistently stated that despite AI assistance, the ultimate responsibility for patient safety and safe performance of the procedure remains solely with the anesthetic. So transparency, users must understand what the model highlights and its uncertainty. So we need a robust, secure, we need something robust and secure. So system must resist cyber attack and perform outside the training set. So we're gonna look at respect and privacy. So embedded encryption, we need strict access and audit trails. So and then we know like the human and AI collaboration. So AI is a decision support, not an autopilot. So practical challenges, we're gonna have some data quality bias. So we have to know like garbage in, garbage out. So anything poorly labeled image propagate errors. So if you don't think it's a good data, we need to get rid of it because it's just gonna not be good data for us to advance or learn from. But I guess we can learn from it. So over reliance, we have so because of the AI showtime, they will color overlay. They can create a false confidence. So any hazard, return expert sonar anatomy skill. So even though those new technology is really helpful, we have to also maintain our skills and our knowledge. We cannot just rely on those machines. So another thing we're gonna look at is lack of standard. So there's a few RCTs and no universal guideline for AI in regional anesthesia. So clinical bodies must lead validation. So we're gonna look at cost and barriers. So high-end system may be unattainable in smaller centers. So there is an equity issue over there. So some big hospital might have the budget for it, but if you work in a smaller hospital, you might not get to use those kind of technology. So AI and robotic promises safer, more precise nerve blocks, but only when paired with rigorous data stewardship, transparent algorithms, standardized validation, and unwavering human oversight. So we're gonna look at implication in nurse anesthesia practice. So there's an enhanced safety and visualization with AI-enabled ultrasound. Those are the scan knob. This instantly detect and color codes nerve vessel pleura. There's no need to hunt for any anatomy. So the needle tracking algorithm predict the tip location and it will warn you about the risky trajectory. So when we look at complication and avoidance via pressure and imaging, so we have the pressure injection pressure monitors like the Sapphire and the Nerve Guard that will like instantly stop the flow anything greater than 15 psi. That if it stops it, that means like you are pretty much in an internal entry. So combined with the AI overlay, the risk for any nerve injuries, any vascular puncture, or in the pleural, that will drop. There will be less injuries to that. For efficiency and ergonomics, so there is the study that has been done. So AI guide trim down femoral and venous access to approximately 80%. That is on par with seasoned clinician for any novice anesthesia. So we're gonna to optimize local anesthetic use, we get a better visualization. That means smaller volume will achieve the same spread and lowering systemic toxicity risk. Another benefit that we get is the education and skill transfer. So AI system highlight, which is a cognitive salient anatomy. It offers on-screen tips and it's replayable technique video. This accelerating any ultrasound regional anesthesia training. The workflow impact the that has automated guidance could allow trained CRNA or advanced practice nurses to perform tasks that once demand an attending. This is like improving throughput and cost effectiveness, and also provides security, privacy, and ethic closing. Despite tech assistant, CRNA remain accountable. So mandatory encryption, anonymization, bias audit, and robust governance. So informatic and pressure monitoring plus the AI ultrasound, this elevate the block safety, the speed, and it also education. So, but only when paired with vigilant and human oversight. So in conclusion, these informatic mechanisms offer tremendous potentials for non-anesthetics to enhance precision, efficiency, and safety in visual anesthesia procedures. However, the success in ethical integration demand that nurse anesthetists remain vigilant in maintaining their foundational critical expertise, understanding the limitation of AI, and actively participating in the development of robust regulatory and ethical guidelines to ensure optimal patient outcome. And here is our reference for the slide, and the reference continues over here. And that is all for today. Thank you so much.